This is a gentleman that presented to me, and he had a lot going on. As you can tell, his gingival tissues are not good. He had some old bonding, some composites, some things. We start to get all of this cleaned up. Notice the technique where I've done a wax up. We make a stent out of a Siltec material, and then we use various materials to create a shell. I tend to use flowable composites as an initial material. I will use a material from DMG called Luxa Crown as a material. You can use a bisacryl as material. But here you see the shell of structure that is made. And you'll see that we start to adapt that through the techniques that we're going to look at to get in place. And then we start to adjust and to contour and to polish. And it's utilizing these techniques that we can get some dramatic changes with soft tissue. We can verify aesthetics before we transition to permanent restorations. So at the end of the day, we've got a lot of choices in terms of how do we do this, but my interest is doing something in a way that we can get a great outcome, whether that's verifying aesthetics or whether that's verifying biology, whatever it might be. I would tell you that back in the day, this is my wife and I. You can see I'm really looking good right there. So we were dressing up for a silly party that my lab technician, the guy on the right with me there, that was having. And, you know, I thought I was dressing up as a basketball player or something. It turns out who's the guy that did all the workout things that, I don't know, you know the guy, but that's who I really ended up looking like. It's kind of frightening. I was trained as a technician with Jeff back in the day, and Jeff ended up opening a lab in Dallas, Texas, Singular Dental Ceramics, and that's who I still use today. And then I went on to dental school and did my thing. But what I've done is I've taken some of the techniques that I learned as a technician, and I've applied those to my world of what I do in regards to dentistry. So keeping that in mind, as I just mentioned, I was trained as a lab tech. I'm in private practice. My fingers are in the mouth every day trying to make a living, just like all of you. I do teach at our dental school. I'm there only half a day a week. I'm just so incredibly fortunate. I've got a new associate who is going to become a partner in my practice that I met through the residency program there at OU that has joined my practice, Dr. Cam McCord. So I've got that opportunity to be at the school. I also play at the Institute. And for those of you that have not been to the Institute, I'm just telling you flat out, there's just not a better place to be to change your world of dentistry, whether it has to do with the technical aspects of what we do or the philosophical aspects of how we practice and how we live. I would highly encourage you to consider the Institute. That's why I'm here, by the way. I'm not here because I'm getting a big paycheck. I'm here because I believe in the Institute and I believe in what they do for dentists. So keep that in mind. Also, I have got no dog in this hunt, okay? And so nobody's paying me to say great things about their stuff. I am going to talk about stuff that I use every day. And I'm also going to tell you that some of the stuff I do every day is just horrid. I mean, don't think for a minute that everything in dentistry because we can get up here and talk about it, it doesn't always go perfectly. It just doesn't. So keep in mind that some of my dentistry really does suck. The other thing I'll tell you is this, that DMG has been a big supporter for me in my courses. DMG has material Luxa Crown. They have Luxa Temp. They have some of the flowable and packable composites that are used. They've been good to me because they help support some of the hands-on courses. The techniques we're going to talk about today, I actually have a hands-on course that I do in conjunction with the Institute. I actually have this hands-on course I do through Fling Seminars. And we are going to be teaching this technique in E4 at Pankey Institute. So with that, I appreciate DMG and their support because it allows us to just make it better for everybody. So I've been working on this thing for about 6.5 years. This is a Daytona prototype car, and it's kind of noisy and loud. This was the first time I had it out after I got it started. That's my daughter in the seat. You can see it's not on the ground, it's on the rollers there, just out of my garage. it looks fast just sitting there, but when you open everything up, we understand that it's the stuff under here that really makes it fast. It's the engine, it's the suspension, it's all of those things. And in dentistry, it's the same way. We can make stuff look good, but at the end of the day, if it doesn't function well, if it doesn't have a great suspension, if the motor doesn't work well, it doesn't matter. It's not going to go fast. So in dentistry, it's the same thing. We can make it look pretty, but if it doesn't function properly, we're going to lose. So I find that I do a lot of stuff in dentistry as a trial to figure out what do I want before I transition into anything permanent. Now, because I do love cars, this was the first time I had it out on the road. I took it up to the gas station. This gas station is only, maybe a mile from my home, if that far. And I don't know if you can see back behind here, see where it says, that's not the OND ICE. That happens to be the police. He pulls up behind me and I go, oh crap, I'm in trouble. Well, he comes over and he says, hey, I just want to see the car. So I showed him the car and that was a lot of fun. It's about to go to the interior shop. I got the thing painted and got it done up. Is that not just the coolest thing since Christmas? I just love that thing. And so it's a lot of fun to mess around with and to have fun. After I got the license tag there, that says barely legal. I want to be really clear. That has to do with the car being barely legal and not to female occupants that might be driving in the passenger seat, okay? So my wife wanted me to make that very clear. So anyway, that's a little bit of fun. I love making things like that. Now, in dentistry, here's what I want to share with you. It's this. I think one of the biggest challenges we face in practice every day is the fact that we're trained in dental school to work on teeth. And my contention is that we really need to work hard on dealing with the entire system first. In other words, if we have a broken tooth, what caused it to break? What can I do to ensure that I just don't fix the tooth and it breaks again? So I like to look beyond the tooth and look at the entire system. So because of that, I spend a lot of time in my lab. In my lab, I've got a lab bench. I tell you, I think it is one of the most critical pieces of equipment in my office. I use it all the time. I just don't know how I could be a restorative dentist without it. It's nice because it's got a deal you pull out right here. It's got vacuum that's built in. It's got color corrected light. I've got compressed air. I've got my wax spatula. So they're so critical, and with, at least for me and what I do, to have the appropriate materials and equipment to do what I do. Now, if you don't have a great waxer, this is the one to get. This is a waxer from Whitmix. If you contact me on my email and you want a special price on it, holler at me. I have zero kickback on this. The only reason I promote them is I do a waxing course, and they provide these for me in my waxing course. The reason I ask them to provide them, because I've got 4 different waxers that I've used over the time, and this is my favorite one. So I went to Whitmix and I said, hey, could you help me with the course? And they said, sure. This waxer, they have it in a 2-pin version, and they sell it for like $230 or so. It's like nothing. And it's a great waxer. So if you're going to do some of the things we're talking about, you're going to need one of these waxers. So keep that in mind as we go forward. Now, I want to share just a few quick clinical techniques with you. This is a lady that presented to me. She obviously needs some grafting, and her granddaughter's about to get married. She wanted her teeth, the incisal edges fixed a little bit longer before the wedding. So we didn't have, we're not doing the grafting or anything yet. So I said, okay, let me help you here. I thought back to my days in the lab. And I said, if I were building this out of porcelain, how would we have done it? And as what we would do is we would have a wax up. From the wax up, I would make a stent, just like you see here. The stent would be placed on the lingual of a model, of a working model, and that's what we would stack our porcelain into to build up the crown. So I just thought to myself, why in the world don't we do that when we're doing restorations? So here you see, I've done my wax up, I've made a Seal-Tech stent, I cut it back. Now notice I get a sharp scalpel and I cut through the interproximal here. Here you see my mylar. There's 1, there's 2, and there's 3. Now my interproximals are separated. I can now etch, prime, bond, start to lay my composite in. And now I've got an easy way to build up the shapes of these teeth, and my interproximals are open, and it makes that appointment go a lot quicker. So that's one of the techniques that I'll use. Let me share another thing with you that you can take it and use tomorrow in your practice. It can be a real lifesaver. You know, we're talking about aesthetics and what makes it pretty. This is a lady that presented to me. She had been in my practice for many years. She was a flight attendant for Southwest Airlines. She moved out to California. And while she was out there, she lost a front tooth and she ended up getting a bridge. And she comes back to Oklahoma after retiring from Southwest. And she said, Dr. Flynn, can you help me? Notice what she's got right here. There's a defect there. It's at least 8 millimeters, maybe closer to 10. It's a really large bony defect. So we do a lot of stuff. We get her prepped, we get her provisionalized, we have multiple bone grafts done. We've got 2 fixtures put in place here. Notice that we've developed papilla right here. So that's turned out pretty nice. And then we transition with our custom abutments and all the fun things we typically do. And here she is in her final crowns. Now, here's the deal. To make these final crowns look really good, the thing I had to do was make sure when I got the photograph that spit bubble right there was right in the papilla area to block the dark hole that you see. That was the real trick. So here she is a year later, and here she is 2 years later. And it's no bueno. And so she calls me and says, Dr. Flynn, what can we do? I call my oral surgeon, Dr. Rob Bryan. I said, Rob, can you help me? He said, Mike, I got no more ammo in the gun. We're done here, buddy. There's no bone, there's no blood supply, there's nothing else I can do. Well, the fortunate thing was that these were screw retained, implant retained crowns. So I was able to take them off, and look what I've done here. This is pink composite. I've etched, I've primed, I've bonded. Because this is not under any functional load, this holds up really, really well. So here you see the mylar strip in here. So I built the composite up on the central. I have my mylar strip in. Now I'm going to do the lateral, and you can see she can still get floss up into here. She can go under this and clean it. And these hold up just really, really well because they're not under a load. Now, the beauty of this stuff is, here's where I get it from. Again, I've got zero financial interest in this, so I'm not telling you to get this because I make a buck off of it. I order it just like you do. This is the company called Annexdent. There's her phone number. That's the kit I get. They have this composite in flowable. They have it in packable. They have it in light pink. They have it in dark red. I mean, it's almost in a purple color. The point is, you can mix and match these colors to really, really, really match soft tissue. And so that's a technique that I'll use to save me sometimes when we've got scenarios like we had with her. So let's keep that in mind. One of the things I'm doing right now on behalf of the Institute, and one of the lectures I do a lot with Flynn seminars, is I teach a restorative sequence. And there's 2 components to it. There's the diagnostic footprint. In other words, in the lab, what do we do to figure out how to treat somebody? And then there is the clinical component of it. We go into the mouth. Now, what are the steps we use to treat that? So with that in mind, remember what I said, the diagnostic footprint is the part that we do in the lab. And these are the steps that I go through. And I'm not going to spend a lot of time on these other than to say, going through these steps, I do a lot of diagnostic wax-ups in my practice. I'm at the lab bench a lot doing them myself. Now, it's probably not practical for most dentists to do your own diagnostic wax-ups. You know, you may not have the time, you may not have the, you know, you just may not enjoy doing it. That's the reason I do it, because I like it. I just think it's fun. So if not, I still want you to get a diagnostic wax-up, which would typically be from your lab technician. When I'm doing a wax-up, in this case, I've got severe wear and I have teeth that are worn and are very short. So is what I teach is the concept of the length of the tooth should be about 25% longer than the width of the tooth. So I measure the width from interproximal to interproximal. I established that width, and now I understand the length of that tooth should be about 25% longer, which would put it down to about maybe right here. If that's the case, if it's 25% longer, then I have to figure out where does the incisal edge go? Because if I bring this down and make it 25% longer, that might not fit in the smile properly. So it might be that even though I want the tooth longer than it is wider, instead of bringing incisal edge down, maybe I need to raise gum line up, or maybe a combination of both. So those are some of the things I got to start to figure out. So I'm constantly in the initial phase trying to figure out what can I do to make it pretty. Because once I get it pretty, it's clear that often if it starts to look nice, it tends to function pretty well too. After I get the anterior segment completed, which I've done here, I then get the lower posterior plane of occlusion level from front to back, side to side, and then I simply wax the upper posterior to meet that. So in a nutshell, that's the process that we teach. So if I asked you to do a diagnostic wax up, a full mouth wax up, is what you're going to ask me is, you're going to say, Fling, are you kidding me? That's just a lot of work. And it is. So I'm going to give you some tips and techniques to cheat so that you can make this happen a lot more quickly. This actually, some of these techniques develop from a waxing course that I do. I'm actually going to be in Seattle in September doing a waxing course with their Academy of General Dentistry program there. And it's a really interesting course. I teach people to wax like you draw. So before we ever start to wax tooth number 6 through 11, the first thing I'm going to do is teach you how to draw it, because we wax like we draw. So again, I utilize some of those techniques from the waxing course that we apply to some of the processes that I'm going to teach you now. So with that, I've got a wax up that I've done. And in this, we typically have 2 sets of models that we do with our diagnostic study models. I have one set that's mounted. We pour them in a white stone or a white plaster. We mount them with a white mounting plaster. And the only reason I use white everything is because it's pretty. It just presents well to the patient. The second set of models is what we do our diagnostic wax up on. So when I'm consulting with the patient, I have before and after. So it's a really nice way to let your patient see what it's going to look like, and for you to understand what is it going to function like before you ever begin. So if you're going to do a wax up, here's what I will tell you. The anterior part is the difficult part to get done. Once I've got the anterior part done, waxing the back becomes really easy. And here's why. If you don't have this little thing right here, go buy one. It's called a Ney Rapid Waxer. You can buy them online. You can get them through the Institute. I think they're like $100. They're like not much money. Here's what you do. That waxer that I showed you earlier, that whip mix waxer, you turn that bad boy up to the highest temperature it will go. And there's a particular type of wax that I wax with. It's called white presentation wax. Okay? And it's what I do is you get the white presentation wax both in stick form, and you can get it in a little tub where you can dip into it to carry it over for your waxing. In the stick form, I hold that stick against the shank of my waxer, and it will drip into this form as fast as you can pour it in there. In other words, you can fill these teeth up very quickly by just melting that into here very quickly. After that occurs, I just let it semi get hard. I then put it under cold water, and you pop these out, and I have waxed posterior teeth. So when I do a wax up, here you see a case where I've waxed his anterior here. The lower anterior, he's got significant dental alveolar extrusion. We're going to have orthodontic intrusion done here. But in treating him, we also determined that we were going to open vertical dimension. So here we are where I've done my wax up to simulate the back. When I did my wax up, notice all of these teeth are from my Ney Rapid Waxer. In other words, I just cut the plaster down almost to the gum line. Then I get a little ball of rope wax and I set onto this tooth here, and I get my preformed tooth and I set it on there. I eyeball it to make sure it's where I want it. I pick up a little wax out of the tub, my white presentation wax with my Whip Mix waxer. I wax around the axial contour, and literally in a minute, you can have a back tooth waxed. And that's why I say getting the front teeth is the difficult part. Once that's done, waxing the back teeth becomes very, very quick. So again, I utilize some of these techniques with what I'm going to train you to do with some of this shell overlay technique. So here you see I put the stuff in there, and I just keep in different Tupperware things at the office. We've got these teeth in here and labeled. So if I want to grab a upper left molar, here it is. I've just got all those pre-done, and so I'm doing wax ups. The teeth are there, and I have access to them, and off we go. Now, as what your technicians won't tell you is in the lab world, there are really fancy formers you can get. They've got them in different sizes, different depth of occlusion, different anatomical forms. So they're fancy ones. The downside to those that the technicians might use is they're very expensive. They're a neoprene type material, and a set of them might cost $500–600. So probably not practical for a lot of us. So I just use that Nay Rapid Waxer. Let me give you some tips about waxing. Here's the deal. Always over-reduce plaster. In other words, when I'm waxing the tooth up, I don't want the plaster in the way, because you're trying to carve the wax back and the plaster gets in the way and it makes it difficult. I'm going to use rope wax to help hold the tooth in place before I wax all the axial contour with my white presentation wax. And I use my waxer, the Whip Mix one, around 200 to 210 degrees. That tends to be the temperature. And like I said, you can get a two-person waxer for about $220, $230. So they're just not very expensive. So take a look at this case here. What I've got here is somebody comes in and they've broken a tooth. So I've already had these teeth pre-made. If you're going to fill these up with wax, don't get your pen and put it in the wax and carry it over and fill it that way. It'll take all day and you'll want to shoot yourself. It's not worth it. Get the waxer that I talked about, turn it up to the highest temperature will go. Get your stick wax, hold it against this shank right there, and it will drip into there as fast as it can. And then you let it harden, you pull them out. Here you see the little piece of rope wax that I put, and then you simply set the tooth on there, and then you complete your wax up. Okay. Let's see what we can do. There we go. So here you see me setting the tooth on here, and then I just add wax in here to create my axial contour. So literally in just a matter of a minute or two, I can wax a back tooth. So it just makes it really, really quick. Here, I've waxed the anterior on this gentleman. Here's his back teeth. So once again, that's cut all the way down. I've just simply added teeth, waxed the axial contours. It goes very quickly. So as I would do this technique in the lab, I thought to myself, is there a way I can apply this in the clinic to make it go more quickly? And that was kind of the invent of what I did with these composite overlays. So with that, in the clinic, the steps that I use to get there are a little bit different. So once again, we're not going to go through it all other than to say, I learned this technique in the lab and now I'm going to apply it in the clinic. Here's another way to cheat. If you want to, you see the website phone number there, and you see the phone number, 877-755-6868. This is where we get silicone forms for anterior teeth. And once again, we fill these with wax and they're kept in the little container. So if I want to wax anterior teeth, we can cheat with that also. They have upper and lower anterior teeth. So I would encourage you to get those too. Now then, I mentioned all of this about how to wax. Keep the plaster out of the way, because if you're waxing these teeth and you're doing this and you have plaster in the way, when it comes time to trim this, the plaster's hard, the wax isn't, and it just really makes it difficult. So we really want to avoid the plaster if we can. Okay, now then, let's look at what I did clinically with this gentleman. This is the case that you just saw where I did the wax up. He has got a lot going on. He's got a bridge up here that's mobile. This tooth is going to be lost. There's an abutment on an endodontically treated tooth here, and an abutment on an endodontically treated tooth here and here, and this is going to be lost. And there's no way I'm comfortable doing a permanent bridge from 6 to 11. So we're going to do implants. In addition to that, he's got heavy dental alveolar extrusion. We're going to do orthodontic intrusion. And in addition to that, we're going to open vertical dimension. The dilemma is, if I'm opening vertical dimension, I am committed to restoring at least one full arch. So if I'm doing that, in his case, I'm committed to full arch, crown, and bridge. Well, that's a lot of money. And this guy's name is Steve, and Steve said to me, Dr. Fleming, I just can't afford it. I've got to find a way to do this over a period of time. Is there a way we could do that? So I simply applied the same technique that I did in my wax up. I simply applied that in the mouth clinically. So in this wax up, I saw that I could create a level occlusal plane here. I knew we were going to have ortho to intrude these. And I said to myself, if I could do that in wax, why can't I do that in the mouth? So I had to think out of the box. Here's what I did. My wax up was done for my Ney Rapid Waxer. I went back with flowable composite and I created thin shells out of my Ney Rapid Waxer. You can see they're so thin, you almost see through them. Okay? Is what I did, and it took me a while to figure this one out. I beveled the tooth here. I etched, I primed, I bonded. I had my shell. I filled the inside of the shell with packable composite. The packable composite kind of served as my rope wax. It was firm enough that I could put the tooth in place and know that I had it where I wanted it to go. I got rid of the excess around the margin. I then would go back with flowable composite and fill in the discrepancies in the margin, and I would cure that. So I had one tooth done. Now, the first time I tried this, I used my Mylar strips in here and in here to try and separate it, and it just was a royal pain in the rear. So is what I finally figured out, the best way to do this is if I'm bonding this tooth right here with the shell overlay, I put a metal matrix, a top of my matrix band around this second premolar here, and I put it around the canine here. Now that protected my interproximals here and here. Then I etched and bonded this tooth on. Once this one was etched and bonded, I would put my top of my matrix band around this tooth and around this tooth, and then I would do this one. So I simply did one tooth on the lower right premolar. Then you see I go over here and I did the lower left premolar. Then I did the second premolar and then the second premolar. When I got back here to the crowns, this gold crown, I went in with their small round burr and I created mechanical retentive areas. And I ran flowable composite down in there and I bonded the overlays onto his gold crowns. And here you see where I etched, primed, I bonded the composite overlays onto the occlusal of either his teeth or to his gold restorations or to his porcelain crowns. Okay? I knew occlusally I had the posterior the way I wanted it to be because I did it in the wax up. So I simply went back on the posterior on the upper and I started to do the same thing, just like I'd done in my wax up. So here you see the composite overlays that I made that I bonded in place there. Here you can see I've done light equilibration to get him into occlusion the way I wanted. And then he is going through his ortho where he's starting to get intruded down here, and we got him in a temporary bridge up here. He knows that he's going to have implants. We know that we're going to have to put fixtures in here to make this long term, but we're just trying to get by right now. Here he was after ortho. Look at the amount of intrusion that was done here. There was a lot. I really played at this point with this wax up, trying to determine if I wanted 3 or 4 incisors. I waxed it up and I ended up only putting 3 of these in instead of 4. I did my wax up. Here you see from my wax up, I have a shell that I made right here. This is my Siltec index material that I made. And this is a thin shell. In this case, I used Luxa Crown. Okay, Luxa Crown is the bisacryl material from DMG. And again, at the time, I was just screwing around with different materials, trying to figure out what works and what doesn't. But this can be a little deceiving. This is a thin shell of material. That's not solid. It goes down the facial wall, it goes over the incisal, and then I run it here onto the lingual so that it's hollow on the inside. Now, here's what you've got to do. This is a critical part to this shell overlay technique. You see that I've got the bisacryl shell that I made here. Write this part down. It's really, really, really important. Trim the bisacryl back until it passively goes into position. That's a test question. Trim it back until it passively goes into position. I have to get this trimmed in terms of marginal length, internally, whatever I need to do so that this passively seats. Because if it doesn't passively seat there, what are you going to do? You're going to get your big old fat thumb and you're going to push it down and it's going to break into 40 plate pieces. So this has to passively go where I want it to go. Now that I have this in a passive fit, I'll etch, I'll prime, I'll bond. Here you see I filled it with packable composite. I seat it into position where I want it to go. I clean up any excess, I cure it. I go back with flowable composite to fill in the margins, and I polish it up, and there are his provisionals. Okay? Now, I had these splinted together. The orthodontist asked me to. He wanted to kind of let that serve as retention so that we don't have a relapse, and it just helped keep those in place. So this was easier because they weren't individual. But that bisacryl ends right about there. My flowable composite fills in the margin. You just play with it to contour it, and then off you go. So that is the provisional that we did with that shell overlay. So here he was now with all of the composite overlays. Now, this is a big dude that was a heavy gritter, big time. And I would tell you that I did these 3.5 years ago. And I would tell you that he has not broken one of them. Now, I'm not going to tell you that you won't break these if you do them. My grace with him is he tends to be a pretty vertical chewer. He tends to be up and down. He was class 3. He's not a heavy grit. He's not a heavy grinder. So that saves me some. But now I've got his vertical open. I got the aesthetics the way I want. And what this does, I can now go back and treat him on a tooth by tooth basis. I can do one crown at a time if I want to. And then of course he's had implants put in, and we've gone back, and here he is provisionalized on the upper anterior. And I want you to look at what this did for his self-esteem. Here he was before, here he is after, and I want you to look at that smile now. Isn't that great? That's spectacular. Okay, so that may not be him, but you get it. So that was kind of the initial case that just kind of tipped me over to doing this technique. So here's the deal. We're going to start by creating something that I can use to create a shell in. I tend to do wax ups and make a stent. Okay? When you make your shell, I almost always do my shell out of bleach colored material. Remember that the shell is really thin. So I tend to use a bleach colored material. And if I want to darken it from there, then the packable composite or the other materials I'm going to use, that's where I change the color to get the shade that I might want. Okay? One of the most difficult parts of this deal is getting them out of the shell. If you're doing, say, 6 through 11, and you've got these thin shells, when you go to try to remove the shell from the stent, sometimes they break. And so the thing you do at that point is you curse it a little. Just put them back in the shell, get a little more flowable, lute it together right there. And I will tell you that for me, often getting these out of the stent is a two-person job. My assistant will kind of hold it open, and then I'll tease it out with some type of instrument, and that can be difficult. Remember what I said, once you have the shell made, you're going to trim it to a passive fit. That's absolutely key. Now, here's another test question. If you've made your shell out of composite or bisacryl or Luxa Crown, any of those things, there's an oxygen inhibited layer. I can add flowable or packable composite to them, and I'll get reasonable adhesion if I'm doing that within the first 24 hours. If I make my stent ahead of time and it's been a while, I don't want to add the packable or flowable or the other bisacryl to it without adding an adhesive product. So I simply go back with my bond, I put it on there, I blow it off, I cure it, and then I can go back and add my other material. Okay? I use packable inside the shell so that I can position it well, and then I tend to use flowable to get the margins the way I want it. So that's the technique. So here's another lady that presented to me. She had a lot going on. She had dental extrusion, so she had a gummy smile. She had vertical maxillary excess. Ideally, it might have been nice to do some impaction. And she has a hypermobile lip. And she said, Dr. Fling, you can fix me, but you can't fix all of me. We're not doing skeletal surgery, so let's do what we can. So I got with my orthodontist. He over-intruded her on purpose because we're trying to hide some of the gummy smile. And we got to a point right here where she said, Dr. Fling, I feel like a goofball. Can we do something? I said, yeah. So I had her run by the orthodontist. He took the wire off. She runs over to my office. We took an impression. I waxed the impression up that evening. Here you see the wax up, here and here. I made a stent of the wax up. I had her come back the next morning. This is my shell that I made right here. This shell is deceiving. It's not solid. Here you see me adding the composite down the facial. I will cure it. I add a little in the lingual. And usually when I added up the lingual wall, it will meet in the incisal, and you cure it and you've got a shell. It needs to be hollow in the middle. I'm going to trim it until it passively fits. I'm going to put packable composite inside. I'm going to seat this in place. I'm going to trim these up just as I described with my flowable composite. And here it is. This appointment to put these in and to bond these in place, I did this in 1 hour. Now, you might be calling BS on this, but I'm just telling you, I really did. If I were free-handing this would have taken me forever. But I literally did this appointment in 1 hour. I made sure it passively fit. I just put packable in there, flowable on the margins, polished it up. Now, here's the problem that occurred with this case. I got it done. Here she is with this. And when she got finished with ortho, they took the brackets and the bands off, and her teeth looked good. And she said, Dr. Fling, do I really need to do veneers? And I said, no, you really don't. They look great. So it turned out so well, we've never restored her with veneers. So that's the technique that we use. Now then, I want to show you that this can really be pretty simple. The dilemma becomes when you want to do a case where they're individual, because it makes it more challenging. When they're splinted, it's easy. When they're individual, it's not so much. Remember, lower anterior teeth in function are in compression. So bonded composite on lower anteriors can work really well if you've got some enamel to bond to. So this is a case that I did with one of my residents. This was his first time to do the technique. So I want to show you that it can really be done quite easily. He did a wax up. Here was the stent that he made. And here you see the shell that was done And I honestly don't remember if he used Luxa Crown or if we used flowable. I don't remember. It was one of the two. But you see, it's just a really thin shell of material here. You got to get this out without breaking it. That becomes the challenge. So your assistant or somebody's going to help you hold this apart, and you're going to tease this thing out, and then you're going to trim it until what? It passively fits. So you're going to get a diamond burr on high speed, and you're going to come in here and you're going to kind of grind these out interior-wise as needed until you can get this to passively fit. And that's what he's doing now. He's trying to get that adjusted where it'll passively fit. After that is done, and you absolutely are sure you have it where you passively fit in the position you want, you get an ultra-thin diamond disc. And as what you do is you go in from the lingual. And here you see going into the lingual, you don't go all the way through. And you leave this connected, and then you get your little fingers and you go snap, and you let this snap apart right here. And then you do the next one, and then the next one, and the next one, and the next one. Get a piece of paper or something on your tray behind you and circle 22, 23, 24, 25, 26, 27, and put these teeth in the numbered circle. Because if you don't, you will go to grab one and put it on a tooth and you'll get it mixed up and it turns into a mess. Ask me how I know. Okay? So this is what Dr. Hooper did. He went in and started to section these. And here you see him putting them in one by one. Okay? He's packing the composite with the packable composite. He'll get rid of the excess. He'll go back with flowable. And this was his first attempt to do it. And you know what? That's a pretty darn good result. And he gets them all polished up. These were individual where you can floss between them and off you go. So I mentioned it in my restorative sequence. As we go through this, we talk about how we want to get occlusal planes level. Here's provisionalization that has occurred. I've got the anterior done. Now it's the lower posterior. In my provisionalization back here, I will use the same technique. I can make a shell that goes from here to here. I can then put packable composite inside of it, and I can seat this until visually I have this occlusal plane where I want it to be. The dilemma on a lot of these big cases back like this is you put a stent in place and you have no stability to get your stent in place. You seat it too far, you seat it too far facial, too far lingual, you seat it occlusally too far or not enough. And now you're scrambling trying to figure out, all right, what do I do to correct it? Well, with this technique, I can make my shell, I can fill it full of packable, I can seat it and eyeball it to know that I have it where I want it. So again, that can save you just a little bit. Now, with the upper posteriors, I do the lower posterior first. So these are provisionalized first. And now I want to provisionalize the upper posterior to the lower posterior. This is just a really, really, really neat technique. So let me go through this with you just a second. This is a lady that presented, and we had ortho done because she had significant dental alveolar extrusion. We had to create space for restorations in the anterior, so we had all the intrusion done. She wanted things to be more aesthetic. Here she is. You can see, you don't even see free gingival margin heights here. And so they end up doing some intrusion. Here you see the upper anterior. There's where we've added composite. We're going to end up restoring all of this. Here's our diagnostic models after the ortho. From that, we're going to do our diagnostic wax up. Here's our diagnostic wax up. We do the upper anterior first. We do the lower anterior next. We then do the lower posterior and then the upper posterior. And again, here you see my little teeth. Notice I've just taken away the back, gotten rid of all of the plaster, get it out of the way, set my teeth on here, and very quickly I can wax the posterior part of this. I get this occlusal plane how I want it. Now I'm going to cut down the plaster on the upper posterior, and I'm simply going to add teeth back there to mate against the lower posterior. And here you see me doing that. And now I have my stents. So now I've got to go and take this into the clinic. I'm going to go through the same process. I make my upper anterior provisional restorations. I do the lower anteriors as we had discussed earlier. I get her coupled. When I do provisionals, I try to use a heavy chamfer or a shoulder. So my margins should be really, really evident. I use a high speed with a diamond burr, and that's what I use to go to get rid of the excess bulk. I just use a diamond. While I'm doing the diamond, my assistant has got her high-speed vacuum going, and she's blowing air the entire time so that I can see what's going on. So that's how I get rid of the bulk of the material after I've seated this in the mouth. So I get those trimmed up. The lower posteriors, I already shared with you how I'll make that shell. I'll put bisacryl, more bisacryl inside of it. I can seat it until visually I have it where I want it. I'll clean up those margins. So now it's time to do the upper posterior. So this is what's really cool. I've done my upper anterior, I've done my lower anterior, I've done my lower posterior. I've prepped my upper posterior teeth. I've made my shell, see right here? And I trim it until it passively fits. So here you see it passively fitting. I don't care about margins like this being exposed. That's okay. Because what am I going to do now? I'm going to fill this with more bisacryl. And because this is a shell, is what I can do is I can fill it with more bisacryl like you see here. This was Luxa Crown that I was using. And now I'm going to go around the teeth and put it around the margins. Now when I seat this, I don't seat it all the way. I gently place it. I don't seat it all the way, and I ask the patient to bite. Now I can maneuver this to get it into the occlusal position that I want it. So unlike the technique where I used to use a stent to do this, I don't seat it all the way. She closes and she helps me identify where the correct occlusal position is. And as what this has done for me, it has dramatically reduced my occlusal adjustment time on these big cases. So now I'm going to remove that. And I'll go back with my diamond burr. I'll relieve the excess. I'll go back with my disc to clean up interproximals. And my occlusal adjustment, whether it's reduction or addition, is just so minimal because I've been able to use this to seat it so that let her occlusion help dictate exactly where that should go. So it really makes this nice. So now she's provisionalized everywhere, and now I can transition into permanent crowns in whatever sequence you want to do. So that's the technique that I use. So keeping all of that in mind, as we go forward, this was a case where I'd actually used the same technique with Luxa Crown, but we did change vertical dimension on her. Here you see the shell, right? So we're gonna fill it full of more Luxa Crown to seat these shells. So here they are where I'm passively getting them to fit before I reline them. And then we'll use that same technique to get her coupled, clean up the margins, and then, you know, just more or less the same thing we just discussed. So then we can transition that. Now then, is what this did is here in the last 10 to 15 minutes, I want to show you how I have now turned this into a technique that makes so dadgum much sense to me. It really kind of rocks my world. I really love this. And I call these transitional restorations. I use Luxa Crown a lot for these because Luxa Crown is a bisacryl material that has got more strength. In Europe, they actually use this as a permanent restorative material. So this is a lady that presents to me. She comes in off the internet. She is limited financially in what she can do, but she wants her mouth fixed. Here's the tooth in question. Now, I can tell you that is what might have happened in the past on this tooth is if I'm going to crown this tooth, I've got very little to no ferrule effect. It's going to be endodontically treated. I'm going to have a post and a core and then a crown. And even with that, the prognosis of this long-term is going to be guarded because I don't have good ferrule effect. So what is a way that I can use these techniques to minimize her treatment? Here you see I'm using flowable composite. In this case, I have made a thin shell, a thin onlay out of my Rapid waxer. I trim this until it passively fits on that tooth. I have removed the decay. I have placed a pin to help with retention. I etch, I prime, I put packable composite inside of it here. I gently seat it into place. I carefully remove the excess. I use flowable to go back and do the margins, and this is her tooth. It's obviously, the most of it is composite filling, but guess what? I contend that is as stable or more stable than if I were doing a root canal, a post and core, and a crown. And we've done this at a fraction of the cost of those other things. So I think it's just a really neat technique. Take a look at this case. This is a lady that is going to have ortho. She's going to have periosurgery. She's going to have grafting done. There's just a lot cooking. I've got breakdown and decay all over. So I've got to get her stabilized before her ortho. I used the same technique. I did a diagnostic wax up. From my wax up, I made a stent. From my stent, I make a thin shell. I trim my shell back until it can passively seat. I etch, I prime, I bond, I put packable composite inside of it. This is a posterior tooth. Look at this. Now, think about what I said. She's going through ortho. If I were doing this my old way, there'd be a core filling, there would be a temporary crown, and the odds are that in her orthodontic treatment, the temporary crown would come loose or we'd have marginal leakage. With this technique, I have made a shell from my Rapid waxer. I put packable composite inside of it. I seat it in place. I bond it in place. Here is her core filling. So here you see it right here. That's what she's going to wear while she goes through ortho. And then after she's gone through ortho, I then can go back and transition that to a permanent crown. So here she is after we did everything. You'll remember that this is all composite right here. The lateral here, that molar back there. And now she's in ortho and the periodontist is doing their thing and off we go. But she's stabilized now utilizing that technique. So I just found this to be a really great technique to help me with that. Now, keeping that in mind, these crowns back here, those are Emax crowns. Look at the anatomy in those. It looks pretty good, doesn't it? People, if you're getting Emax crowns that are pressed from your lab and they don't look like teeth, go find another lab. Because there are so many different techniques for creating these occlusal shells that when they wax these teeth, they should look like teeth. And then they burn them out and press them in Emax. Now, if you're milling, that's a different deal. But if you're doing pressed stuff, they should just look very, very natural. So there was a guy that was fishing and he wasn't doing so well. And he looked down at the end of the dock. And at the end of the dock, this other guy was doing really good. And he went down there and he said, "Man, I'm impressed. You're catching all these fish." He said, "But I don't understand something." He said, "What's that?" "Why is it that you're getting the big fish and throwing them back and keeping the little ones?" He said, "Well, that's easy. I'm keeping them for lunch." He said, "Yeah, but why are you throwing back the big ones and keeping the small ones? He said, well, that's also easy. He said, you see, I only have an 8-inch skillet. Okay? Now, here's my point, doctors. There are times you have to be willing to change your skillet. You just do. And this technique, it definitely requires a skillet change because it's different. You know, before I would have had this kid come in that broke this at school, and I would have been building this up by hand, and it would have taken me 3 hours to do. It just would. But now I can bevel that. I can take a quick alginate impression. I can wax it up in a matter of minutes. I can make my stent. I can make my shell. I can trim it to passively fit. I can put my packable composite inside it. I can trim my margins up, and very quickly I can get something in place there. So it's just a technique that makes it really, really easy, but you've got to be willing to change your skillet. So remember what I said, it's about your choice and about the outcome. That's really what it's all about. This isn't mind-boggling stuff. It's not that you have to be brilliant to know how. The question is, are you willing to do it? And here's what I would tell you. When you start to look at things throughout our life, it's interesting that when you look at surveys of people that are going to make resolutions, I want you to look at this. The percent of people in their 20s who achieve their resolution each year is 39%. People in the over 50, only 14%. Why is that? And the reason is this. The reason is because we get used to doing the same thing the same way over and over and over. And it's really difficult when we have to change our culture to do something differently. And so my point is that this technique is different for sure. It's going to take some getting used to. You've got to do some preparation in terms of a wax up, making your stent, making your shell, but it's just a technique that I think will limit the amount of needed treatment for your patients. It'll make it less expensive and make it more predictable for them.